Okay.
دكتورة كأنه صوتك مختفي.
No, I am not talking.
اوكي
We will start now. Okay. طيب.
تمام.
Okay. طيب. يعطيكم العافية. إحنا last class we started talking about treatment of metastatic colorectal cancer وحكينا about chemotherapeutic drugs أو chemotherapy. We started talking about biologic drugs. Biologics قلنا إنه هدول only approved with metastatic disease أو stage 4 disease. And they belong to two groups, angiogenesis inhibitors and EGF receptor inhibitors. And we started talking about angiogenesis inhibitors, and we talked in details about bevacizumab or Avastin. وحكينا about its dynamics, its side effects or adverse effect profile, how and where to use it in treatment of stage 4 colorectal cancer. We will discuss it later on. We stopped by the other group of biologics اللي هم ال EGFR inhibitors. هلا ال EGF receptor is a tyrosine kinase receptor. If you recall receptors from pharmacology course, Pharma 1, the tyrosine kinase receptors, they are transmembrane receptors, and they have intrinsic tyrosine kinase activity, okay? The EGFR family contains different receptors. EGFR is the same as HER1 or human epidermal growth factor receptor 1. The EGFR family contains EGFR itself, contains HER1 or EGFR, HER2, HER3 and HER4. يعني HER2 receptor اللي احنا قلنا عنه بالbreast cancer, very important. It also belongs to the family of EGF receptors. فلما احنا بنحكي about colorectal cancer, EGFR is very important and is usually overexpressed, يعني highly overexpressed. The number of the receptors available in the plasma membrane on the cancer cell, in the colon cancer cell, is a huge, okay? Will EGF receptors as a family, they are growth factor receptors, or they are receptors involved in promoting cell division, proliferation, sometimes even invasion, migration, and so on. Very important to the tumorigenic behavior of the cell. In normal situation, EGFR is existing as monomers. Upon binding to its ligand, EGF, okay, it forms a dimer, and then the kinase domain of the receptor is phosphorylated, so activated. And then the active receptor complex, dimer, start to activate downstream proteins or molecules. فمن ال very important downstream transducers هو الRAS. Okay, طبعا في عندنا KRAS and RAS. We have different isoforms, but KRAS is very important. RAS is a small G protein. فبالوضع الطبيعي, okay, the activation of the receptor cause the activation of RAS, and then this is a cascade. So RAS activates the downstream, the next protein or molecule in the cascade, which is BRAF, and then BRAF activates MEK, okay, the next protein. MEK is a transcription factor, so it will move from cytoplasm to the DNA or to the nucleus. It will bind a specific element or region in the DNA, and then it will alter, change gene expression in a way that will promote the growth, the division, the proliferation of the cell, the survival, and so on. فإذا إحنا في عنا هون في pathway, okay, في pathway. بالوضع الطبيعي, if the EGF receptor is not active, is not bound to its ligand, or the kinase domain is not active, the cascade, okay, the KRAS, BRAF, MEK cascade is also not active, okay. هلا احنا حكينا انه بالcolon cancer, especially metastatic disease, if we block the activity of EGF receptor with inhibitors, and if we give a drug that will stop the activation of the receptor, this means that the pathway is inactive or cannot be activated. So indirectly, you also inhibit the activation of the RAS, BRAF, MEK pathway. هلا في عنا group of drugs بنقولهم EGF inhibitors, okay? They are basically monoclonal antibodies. EGFR inhibitors يعني could be monoclonal antibodies or could be small molecule kinase inhibitors. If you remember احنا حكينا عن lapatinib مثلا هو HER1 HER2 small molecule tyrosine kinase inhibitor. لكن the EGFR inhibitors that are used and approved for metastatic colorectal cancer هم monoclonal antibodies, and we have two, panitumumab and cetuximab. Okay, when we give these drugs to patients with stage 4 colorectal cancer, they will bind, they bind to the extracellular domain. They bind EGFR at the extracellular domain, and by binding to EGFR, they will inhibit receptor dimerization and activation. So if we inhibit EGFR with the monoclonal antibody or the drug, the EGF inhibitor, KRAS is inactive, and so the whole pathway is inactive. So you will stop the growth of the tumor, the proliferation of cells, and so on. فبالتالي they are very important drug therapy only approved in metastatic disease, but they have a conditional use. يعني في condition okay لازم تكون موجودة لحتى احنا نعتبر المريض eligible or candidate to consider EGFR inhibitor. شو هاي الcondition؟ the genotype or the quality of KRAS expressed by the cells. هلا بالوضع الطبيعي if we have a wild type protein, a wild type KRAS, what does it mean wild type? يعني ما في عندي activating mutations. It's the regular form of the protein, the one that is normally expressed, okay? فإذا عندنا wild type KRAS, okay, which that mean إنه the KRAS is inactive and only activated in response to EGFR activation. If we have wild type KRAS, okay, then inhibiting EGFR would be of value. ليه؟ لأنه إذا إحنا بنعمل inhibition ال EGFR, the ultimate goal we inhibit this signaling pathway, وبالتالي we stop the proliferation and growth of cells, and we induce apoptosis and so on. هلا in some cancer cells we have mutations in the gene encoding for KRAS. فبالتالي the product of that gene is active. يعني بيكون عندنا mutated KRAS. Okay, the mutated KRAS is usually active, constitutively active, does not need EGFR for activation. Okay, فبالتالي إذا أنا already عندي KRAS in the cell that is constitutively active, mutated, okay? If I inhibit EGFR receptor in these cells with mutated KRAS, okay? Do you think this will be useful? يعني أنا already عندي إنه الKRAS نوعه بالcells هو active أو mutated, activating mutations وهو already constitutively active. Do you think there will be a value of considering or adding EGFR inhibitors to that patient with a mutated KRAS? What do you think? Any idea؟ حدا بيعرف؟ حدا بيحب يجاوب؟ في حدا رافع ايده لأنه أنا مو مبين قدامي إنه حدا رافع ايده. رانيا؟
أنا دكتورة
تفضلي.
دكتورة بتوقع لا ما في إفادة يعني بما إنه هي already active.
Yes, good. يعني إحنا عنا already regardless of EGFR status, okay, regardless of the receptor being activated or not. KRAS is active. If KRAS is active, it will activate BRAF, BRAF activates MYC, and it goes on, right? So if we inhibit EGFR in these patients with mutated KRAS, okay, or to be honest, more recently كمان, ومكتوبة I think in your textbook, حتى the status of BRAF now becoming important, okay? يعني is it a wild type BRAF, is it mutated BRAF كمان هذا صار مهم. فبالتالي let's focus على الكيراس. فبالتالي if KRAS status is يعني عملنا genotyping ولقينا إنه the KRAS in this cancer cell, in this colon cancer cell, is mutated and is constitutively active. In this case, although the drugs are available, they are not indicated. They will not be beneficial, helpful. Okay? فبالتالي, what is the condition of considering EGFR inhibitors in stage 4 colorectal cancer. شو بده يكون الكونديشن؟ يعني هون إذا إحنا بدنا نضيفها أو نعتبر المريض eligible. What is the condition? رانيا mute yourself please. طلاب اللي عم يدخلوا على المحاضرة. رانيا رافعة إيدك؟
لا دكتورة مو رافعة.
أوكي. طيب شو الكونديشن إذا إحنا يعني taking KRAS genotype when the patients in stage 4 are eligible to these drugs. يعني إذا إجا مريض KRAS mutated constitutively active KRAS, is this patient eligible candidate? أنتوا فاهمين أنا شو بحكي؟ حد يعني فاهميني understand؟ حدا يجاوب. أيمتى المريض إذن eligible؟
لازم يكون wild type.
آية
لازم يكون wild type. ما بزبط
يعني
يكون
شو لازم
mutated.
يكون الريزلت اوف genotyping؟ لازم يكون الكيراس ماله wild type. اوكي طيب هلا what is required to consider EGFR inhibitors؟ لازم اعمل testing اللي هو شو لازم اعمل testing لمين لحتى يعني to decide whether the patient can be considered for this drug therapy or not. I have to ask for what؟ شو التست اللي لازم اطلبه؟ شو ينعمل؟ genotyping لمين؟ يعني إذا إجا طبيب مثلا مقيم بالراوند مريض metastatic colon cancer وأعطوه الكيموثيرابي مع الانجيجينسيس inhibitor أو البيفاسيزوماب وما استفاد قال لك let's add panitumumab مثلا okay is this appropriate أو let's switch to cetuximab you say okay all of يعني go ahead ولا في requirement وفي test we have to test for what before we approve it or consider it شو لازم نشيك status of what of KRAS okay فبالتالي we have to do what we call it genotyping to what لا لمين للKRAS okay so the EGFR inhibitors are only and only used okay in patients with wild type KRAS يعني KRAS in these tumors is wild type, is not mutated or constitutively active. If we have the result of genotyping as KRAS is mutated, constitutively active, do not use EGFR inhibitors. Okay? angiogenesis inhibitors, they have advantage, they are not dependent on a specific genotype. يعني أنا مو محتاج any previous data or information to decide whether I have to add bevacizumab to the first line treatment or not. Okay? فهاي advantage لأنه الكيراس genotyping للأسف مش متوفر بكل المستشفيات. I think إنه بالملك المؤسس this test is not available. يمكن موجود بمركز الحسين للسرطان. فبالتالي يعني the need to know the condition or the status of KRAS and wait for the test or to find a place to do the test is sometimes يعني inconvenient. Okay, فبالتالي one advantage of the angiogenesis inhibitors is that they do not require testing. They are approved. Once the patient عنده stage 4 disease, okay, you can consider bevacizumab in addition to the chemotherapy. Okay, فهي one advantage. as we said, فإحنا لما بنعطي ال EGFR inhibitors, okay, the activation of the receptor and dimerization is impaired. وبالتالي the signaling through the cascade, RAS through MEK-ERK, okay, is blocked, and so you block the effect of that signaling pathway. طبعا this is true to both panitumumab and cetuximab, both of them. Okay, they will block receptor activation and dimerization. هلا they are available for parenteral use. Okay, so a very important toxicity هي infusion reactions. يعني infusion reactions. Now, anaphylaxis can also happen. فبالتالي, we have to consider pre-medications to minimize the intensity of the infusion-related reactions, and patient must be observed for any signs of severe hypersensitivity reactions. Another important toxicity هي skin toxicity. Okay, يعني معظم tyrosine kinase inhibitors actually they can cause skin toxicity. Skin toxicity has grades. بمعنى يعني some patients they can develop mild toxicity, can be managed maybe with moisturizers, maybe with topical steroids. Okay, in some cases they can consider antibiotics, for example. يعني skin toxicity sometimes is manageable, but sometimes in some patients it's really toxic, and it might require that the drug is to be stopped. Okay, فإحنا we have to educate the patient about skin toxicity and the gradient of the skin, the grade أو levels تبعت skin toxicity, and they are aware when to come to hospital and to consider interventions. For skin toxicity يعني common with the EGFR inhibitors. The EGFR inhibitors also can cause electrolyte disturbances. Okay, they can influence sodium levels, potassium, and magnesium. Okay, I think it's written in your book. So check what kind of disturbances. يعني هل هم بيعملوا مثلا hypermagnesemia, hypomagnesemia, do they cause hypokalemia, hyperkalemia? Okay, this is something important. We have to check serum electrolytes for patients who use panitumumab or cetuximab. Okay, وين بينحطوا بالتريتمنت كمان رح نحكي عنهم. طيب هلا احنا عندنا many chemotherapeutic drugs أو regimens available in metastatic disease. طيب how to pick to start. يعني إجا مريض chemotherapy naive. شو يعني كلمة naive؟ لما بحكي مريض chemotherapy naive. شو يعني كلمة naive لما بنحكيها؟ حدا بيعرف؟ لما بقول هذا المريض chemotherapy naive. Any idea؟ طيب
إنه أول مرة بستخدم الكيموثيرابي ما عمره استخدمه قبل هيك.
مين عم يحكي؟
براءة.
Yes. إنه ما استخدمه هيك. Yes, very good. Never exposed to chemotherapy before. Okay. فهذا بنقول له chemotherapy naive. يعني this is a first line treatment. Okay. طيب هلا بالfirst line treatment we recommend to start with a chemotherapeutic regimen. This is the recommendation. وإحنا حكينا we have many. Okay. The standard selection is either FOLFOX or FOLFIRI. هذا reference standard. Okay. طيب when we have to consider FOLFOX first or FOLFIRI first. إمتى؟ هلا usually patients with neuropathies, okay, pre-existing. شو يعني؟ They already have a neuropathic disease, disorder, pain. Okay. pre-existing موجودة. يعني في أحيانا كانوا طلاب لما يختاروا الريجيمن مثلا أو يختاروا التريتمنت مريض diabetic فيقول لك لا لأنه diabetic do not use oxaliplatin in the regimen or do not use مثلا another drug. مش كل مريض diabetic هو صار معه neuropathy. أوكي أو وصل لمرحلة neuropathy. مش كل مريض مثلا عنده يعني pre-diabetes هو أكيد رح يصير diabetic. يعني let's not make assumptions. Okay. فبالتالي إحنا بنحكي إذا the neuropathy exists. Okay. If the neuropathy exists actually فبالتالي it's better to avoid oxaliplatin. Okay. Because it will make it worse. It exists, it will make it worse. pre-existing neuropathies of any cause, whether it's a diabetic neuropathy, other form of neuropathy, okay, the best regimen to pick from these is FOLFIRI. Okay, لأنه السايد افكت للأيرينوتيكان بروفايل يعني الريسك أو the chance of neuropathy كتير أقل with this regimen. Okay. طيب when we have to consider FOLFOX over FOLFIRI يعني إمتى نعطي FOLFOX but not FOLFIRI when it's preferred to consider it as the initial choice. We have two conditions here. Whether bilirubin is elevated. وإحنا دائما كل مرضى الكانسر يعني before taking any cycle بينعمل للمريض complete check-up. بنعمل له CBC, KEFT, which means kidney function test, left liver function test. بينقاس له يعني نحسب له الكرياتين clearance إذا بيحتاج urine analysis مثلا is already on bevacizumab مثلا coagulable tests parameters فهدول المرضى بنعمل complete check-up. okay if bilirubin is elevated okay مريض مثلا عنده biliary disease okay عنده liver disease رفع البيليروبين due to any reason avoid oxaliplatin and avoid irinotecan and use oxaliplatin containing regimen instead. فهي كتير مهمة. Okay. The other important thing that we have to definitely exclude FOLFIRI and go to FOLFOX لما يكون في عنا deficiency in a metabolizing enzyme we call it UGT1A1. هذا enzyme كتير مهم ورح نحكي about personalized medicine at the end. حدا عنده فكرة هذا الانزيم ايش بيعمل؟ UGT1A1 أو شو علاقة هذا الإنزيم يعني the deficiency of this enzyme in avoiding أو omitting أو مثلا استبعاد ال irinotecan based regimens لهذا المريض حدا بيعرف؟ حدا بيعرف شو علاقة هذا الإنزيم بال irinotecan metabolism؟ يس دانا؟ تفضلي.
هلا أنا ما بعرف إيش بيعمل بالضبط بس أنا بعرف إنه هو ريسك فاكتور إنه يصير في عندي delayed diarrhea.
Good. ليه؟ يعني toxicity للريجيمين بتزيد right؟ right؟ يعني إذا عندنا UGT1A1 deficiency the irinotecan toxicity is increased. طيب why؟ حدا بيعرف هو it's a metabolizing enzyme. It's responsible for metabolism of what؟ طيب شو الactive metabolite؟ إحنا حكينا irinotecan produce anti-cancer activity but the cytotoxicity comes mainly from the active metabolite اللي هو شو؟ حكينا المحاضرة الماضية شو الactive metabolite للirinotecan؟ شو اسمه؟
CD38.
Yes, good. SN38, right? طيب, what is the relation between SN38 and toxicity with this enzyme? هذا الانزيم will metabolize irinotecan or SN38? مين التوكسيك very toxic metabolite حكينا احنا؟ يعني accumulation of SN38 becomes more toxic or irinotecan accumulation is more toxic? Yes, Sanar. الميتابولايت right؟ فبالتالي
بيعمل ميتابوليزم ضد الميتابولايت.
Yes, excellent, good. فإذا إحنا حكينا إنه irinotecan most important and most active cytotoxic metabolite is SN38. Okay? يعني معظم anti-cancer activity اللي إحنا بنشوفها in cytotoxicity comes from the metabolite, not irinotecan itself. And we do not say إحنا ما بنقول إنه irinotecan هو pro-drug, it's not a pro-drug. But if we compare the anti-cancer activity or cytotoxicity, SN38 is much more cytotoxic, okay? UGT1A1 normally metabolizes, detoxifies SN38 into inactive metabolite. فهو بيعمل له clearance وبيقلل التوكسيسيتي. فإذا في عنا deficiency, especially إذا كان في عنا يعني severe deficiency, no activity of the enzyme at all, okay? We should avoid irinotecan-based regimen. Actually, not only FOLFIRI, مش بس الفولفيري. بيكون عندنا UGT1A1 severe deficiency. We have even to avoid FOLFIXIRI, IRAX رح نحكي عنها. And you have to avoid irinotecan in the regimen. Otherwise, SN38 clearance metabolism is very slow or maybe impaired completely إذا كان الإنزيم deficiency severe. It will accumulate, it becomes very toxic. to regimen, okay, and to patients. But this is very important with irinotecan and SN38, okay. الفولفيكسيري it is approved as a first line treatment, لكن احنا حكينا this is more aggressive regimen, okay, and we usually reserve it to patients who have really aggressive presentation. شو يعني؟ يعني المريض جاي مثلا metastatic colon cancer, several lesions involved in liver or maybe liver and lung, okay, يعني very aggressive presentation. We can consider it, okay, لكن routinely, although it is a first line regimen approved, you can use it. احنا بنفضل to reserve it, okay, ما نعطيها is not a very good selection to start with, as long as Folfox and Folfiri are available, okay, we can use one of them based on patient condition, maybe liver function and so on. فبالتالي هي موجودة لكن لا يفضل إحنا نعطيها للaverage presentation أو يعني للregular presentation reserved to the very aggressive symptomatic disease. الفلوropyrimidines alone, يعني الكبسايتابين alone, or the 5-FU and folinic acid together, okay, without irinotecan oxaliplatin, يعني هدول الفلوropyrimidines only, they are still approved for metastatic disease, as well as احنا حكينا عنها بالadjuvant disease. However, they are still inferior in response. يعني if we don't add irinotecan, if we don't add oxaliplatin to the fluoropyrimidine in the metastatic disease, they can be used, but they are not as good as the other regimens. Capecitabine can be used alone, okay? 5-FU can be used with folinic acid without the other drugs. However, if there is no reason to exclude irinotecan or oxaliplatin, then the patient is receiving suboptimal management, okay? فإحنا ممكن نعطي الكابسايتابين أو 5-FU folinic acid without the other drugs if there is a reason not to consider it. يعني في toxicity للirinotecan أو oxaliplatin, hypersensitivity, الأدوية مش available, for example, okay? Otherwise, لا. It is not a good regimen to start only with a fluoropyrimidine, okay? ونفس الفكرة حكيناها بالadjuvant. يعني بالadjuvant, it's always good to add oxaliplatin, okay, the fluoropyrimidines. You can use fluoropyrimidines alone, even in the adjuvant, but the outcomes are inferior, okay, compared to the fluoropyrimidine oxaliplatin. فهم available. هلا في عنا regimen بنقولها الIROX. بهاي الريجيمن احنا عندنا ايرينوتيكان ايرينوتيكان and oxaliplatin، اوكي، ما عندنا فلوروبيراميدين، ما عندنا كيبسايتابين او 5-FU. هلا المرضى اللي هم not candidates to the fluoropyrimidines، هي مثلا مريض عنده hypersensitivity reaction to 5-FU. الكيبسايتابين eventually will release very high levels of intracellular 5-FU. أو المريض مثلا اللي صار معه severe toxicity مثلا of 5-FU or capecitabine could not tolerate the fluoropyrimidine drug, okay? هون ما عنا options كتير but to go to IROX for example, okay? However, this is very inferior. يعني هاي regimen inferior actually, not even only to the Folfox or Folfari, حتى compared to the fluoropyrimidines, it's not as good as single fluoropyrimidines. فبالتالي هاي reserved only if fluoropyrimidines cannot be considered, cannot be tolerated, or turned out to be very toxic, okay? We can try IROX, however, this is inferior, okay? هلا I think, I'm not sure if this is written in your books or not. You can actually add irinotecan to capecitabine, okay? يعني الفولفيري احنا عم بنضيف الايرينوتيكان لل 5-FU, okay? In practice, you can actually even add it to capecitabine, okay? طيب هلا ال angiogenesis inhibitors, where to use them and how to use them? ال angiogenesis inhibitors احنا بنقسمهم into different groups أو into levels, okay? Some angiogenesis inhibitors are recommended to be added to first-line therapy. يعني في أدوية في angiogenesis inhibitors, it is recommended they are approved to be considered in first line. And you have to consider them if there is no contraindication. Okay, بمعنى إجا مريض عنده stage 4 colorectal cancer أو colon cancer we decided to start treatment. Let's assume it was not resectable and we decided to start treatment. We decided to go to FOLFOX, for example. Okay, type. Can we add angiogenesis inhibitors to the first line treatment or not? Actually, it's not you can. You have to, unless there is a contraindication. But which angiogenesis inhibitor? Because we have several angiogenesis inhibitors approved in metastatic colorectal cancer. The first line angiogenesis inhibitors is always bevacizumab. يعني أول angiogenesis inhibitor I think about adding it to chemotherapy, okay, هو الأفاستم أو البevacizumab. You don't skip bevacizumab and go to, I would say, zev aflibercept رح نحكي عنه هلا أو regorafenib مثلا without a trial of bevacizumab. البevacizumab هو الموست يعني well documented use يعني empiric experience معه very good, okay, very robust. فبالتالي أنا عندي أكثر من angiogenesis inhibitor. Okay, the very first one to consider and to add to chemotherapy in first line هو البevacizumab unless there is a contraindication. I cannot use it. Okay, طيب bevacizumab compatible with any chemotherapy or with special regimens. يعني can I add bevacizumab to irinotecan containing regimens, oxaliplatin, capecitabine? Bevacizumab compatible مع كل chemotherapeutic regimens. You can add it to any regimen. If you decide to start FOLFOX, you can add bevacizumab. If you start to add FOLFIRI, FOLFOXIRI, CAPOX, على فكرة الCAPOX كمان approved. If you start capecitabine irinotecan, you wanted to add bevacizumab to that, doable. فبالتالي it has very good compatibility, can be used with any first line chemotherapeutic regimen, recommended to be considered unless a contraindication. طيب لنفترض مريض مثلا اجى metastatic colorectal cancer وأنا ما أعطيته bevacizumab. ما كان في سبب لكن إني ما أعطيته. This is not wrong, but it is not the most appropriate. It's not the optimal. Okay, يعني ما بقدر أقول إنه غلط إنه only considered FOLFOX or only considered FOLFIRI مثلا. But if you hold bevacizumab for no reason, this is not the best approach. Okay, فإحنا بنحكي دائما about approach. ليه؟ لأن clinical trials showed that adding bevacizumab to first-line chemotherapy highly improves outcomes, especially in terms of overall survival, disease-free progression, okay, and so on. فبالتالي it's not wrong not to add bevacizumab, but it's not the best management you can give to your patient if you just hold bevacizumab for no reason. هيك بس أنا ما بدي أعطي. Okay. طيب, can we use bevacizumab as a monotherapy? يعني can I add bevacizumab only to patient with stage 4 colon cancer مثلا? البevacizumab is not approved as monotherapy in colon cancer. فبالتالي you should always add bevacizumab to chemotherapy. Okay? هو يفضل ينحط من الفيرست لاين. Okay? إلا إذا في سبب إنه ما ينحط. Otherwise, it's better to recommend adding bevacizumab to the patient. طيب, ال other angiogenesis inhibitors رح أحكي about couple drugs later on. Some of them can be approved as monotherapy. Some of them, especially monoclonal antibodies, should be added. Okay? فإذا إحنا بنحكي about bevacizumab by approval, add on, not use as monotherapy. طيب, the other group of biologics, the EGFR inhibitors. When to consider them? First of all, we have to do KRAS genotyping. Okay? Wild type is an you can consider them. Mutated or constitutively active, خلاص, the patient is not a candidate at all at any phase of the metastatic disease. We cannot consider EGFR inhibitors. طيب, إذا كان المريض عنده wild type KRAS, okay, and metastatic colon cancer, إمتى إحنا بنضيف ال EGFR inhibitors? EGFR inhibitors can be added to chemotherapy in first line, اوكي لأن ممكن المريض اجى عنده stage 4 disease wild type KRAS. I decided to start with Folfox and an anti-EGFR inhibitor بيصير okay FOLFIRI and with plus panitumumab. That's okay, so you can add them okay to the first line chemotherapy, or sometimes you can use them as monotherapy. يعني ال EGFR inhibitors are approved as monotherapy. You can use cetuximab alone. You can use panitumumab alone without chemotherapy, okay? But bevacizumab is not approved as monotherapy. Always added to chemotherapy. فاللي بيحكم ال EGFR inhibitors هو ال KRAS status. This is very important, okay? To be honest بالpractice معظم الريجيمن يعني البروتوكولز أو الابروach بشكل عام إنه consider the angiogenesis inhibitor first, okay? وعادة يعني unless there is a contraindication to consider angiogenesis inhibitors, we can go then to EGFR inhibitors if KRAS wild type. لأنه البيفاسيزوماب has very good يعني history يعني very good experience when added to chemotherapy. بنفضل دائما when we want to add a biologic يعني نختار مثلا اوكي المريض عنده KRAS wild type وممكن ياخذ ال EGFR inhibitor. طيب should we consider in the first line, should we go first with angiogenesis inhibitors? Should we try bevacizumab first, or should we add cetuximab or panitumumab? Which one to go with? إذا كان مريض candidates to both. We pick one of the biologics, okay? مع الكيموثيرابي. يعني معظم الابروach هو بيروح مع الافاستن، بيروح مع البevacizumab. Okay, if you decide to go to cetuximab with the chemo or panitumumab in first line, this is not wrong. Okay, لكن إحنا بنحكي about يعني empirical experience أو approach in general. Okay, هلا sometimes if you don't have the test, if you cannot do genotyping, then you should go directly with bevacizumab if no contraindication, because you cannot answer the question whether the patient is eligible to EGFR inhibitors or not without genotyping. Okay? يعني إذا المريض candidate, you can add EGFR inhibitors or bevacizumab, بس بشكل عام إحنا بنفضل البevacizumab بالfirst line regimen. Okay? طيب هلا مرضى الميتاستاتيك disease okay يعني للأسف part of the nature of the disease okay احنا حكينا إنه مش ما بنعتبر الميتاستاتيك disease هو curable okay expected during the disease time إنه يصير relapses, or in some patients actually they might not respond adequately للfirst line regimen وممكن يصير progression. شو يعني progression؟ يعني after couple of months مثلا شهرين من الكيموثيرابي بنعمل reassessment بنلاقي إنه a new lesion appeared أو بنلاقي مثلا إنه اللابس للمريض deteriorating أو بنلاقي إنه في مثلا lesion increased in size or something يعني any sign that the patient is not stable أو في deterioration إحنا بنقول له disease progression. Okay. This is a likely scenario بالmetastatic disease, okay? If we started a first-line treatment, we monitor the patient. طيب, what should we do in case of progression? يعني إذا المريض stable, افترض إنه the patient has a stable disease. We proceed with the same first-line regimen. كمل عليها, okay? طيب, if because of any reason we decide إنه there is disease progression, في which means شو يعني في disease progression؟ يعني your initial treatment, your first line treatment was not good enough to control the disease. But what should we do here? We have to move to what we call it second line therapy. Okay? But how to move from first line to second line therapy in metastatic colon cancer? We have يعني two very important rules. First thing is to change the chemotherapeutic regimen from one to another. طيب شو بنغير؟ If you start with oxaliplatin-based regimen, يعني نفترض إنه أنا خلينا ناخذ very classic case. خلينا ناخذ مريض colorectal cancer دخل عملنا له assessment. We started Folfox. خلينا ناخذ very يعني straightforward example. بعد شهرين لقينا إنه في disease progression. What should we do? Okay. You have to change the skeleton of the chemotherapy. فبنغير من الأوكزاليبلاتين based نروح على الأيرينوتيكان based. والعكس صحيح. إذا المريض أخذ irinotecan based regimen in the first line, we shift or stop and switch to oxaliplatin based. فإحنا رح نخلي المريض still using the chemotherapy, but we will shift or switch the regimen. Okay. هلا, if the patient at the first line therapy was not using, يعني إذا أنا لما أعطيته first line therapy I did not start angiogenesis inhibitor. ما أعطيت الأفاستين مع الريجيمن. Okay. It is recommended after disease progression in second line, highly recommended to add Avastin. Okay. طيب إذا كان المريض بالفirst line therapy مثلا is not taking EGFR inhibitor. Okay. يعني مثلا أنا مش قادر أضيف الأفاستين لكن المريض ممكن ياخذ EGFR inhibitor. add EGFR inhibitor. Okay. طيب إذا المريض صار معه مثلا severe toxicity of chemotherapy أو لقينا إنه switching from one chemotherapy protocol to the other is not useful. وهاي بتصير على فكرة يعني ممكن نضطر نروح على third line regimen. Okay. Can we shift to monotherapy with EGFR inhibitors? Yes, we can. Okay. طيب إذا كانوا already المريض مستخدمهم بالفirst line therapy، إذا استخدمهم بالفirst line therapy وما أعطوا effect مع الريجيمن أو مع الكيمو، there is no point to consider them as monotherapy. Okay. فبالتالي how we can change the regimen, it depends on what was the first line, to be honest. فبالتالي okay حسب المريض شو كان ماخذ اوكي احنا بنقرر نعمل الموديفيكيشن. فاذا كان ماخذ اوكزاليبلاتين بيز مثل ما حكينا يفضل انه يتحول على كيموثيرابي اوكي لايك فولفايري او ايرينوتيكان بيزد اوكي ونضيف له either اذا ما كان عم ياخذ EGFR inhibitor وكان candidate كان KRAS wild type نضيف الانجيوجينيسيس نضيف عفوا ال EGFR inhibitor or نضيف البيفاسيزوماب. Okay. إذا كان irinotecan based we switch to oxaliplatin based. Okay. وبنضيف إذا ما كان ياخذ EGFR inhibitor أو Avastin بنضيف واحد منهم. Okay. هلا إذا صار progression على second line نفترض مريض كان مبلش مثل ما حكينا فولفوكس وما كان عم ياخذ Avastin صار معه disease progression رحنا على فولفايري plus Avastin. Another month or two عملنا a new assessment ولقينا إنه في disease progression. Still there is disease progression. لنفترض إنه هذا المريض كان KRAS mutated ما كان wild type. فإذا we cannot add أو shift يعني إحنا ما فينا نعطي البيولوجيكس سوا. فيا بنعطي الانجيوجينيسيس inhibitor يا بنعطي ال EGFR inhibitor. طيب إحنا ما بنقدر هون نغير على ال EGFR inhibitor. What can we do? Okay. We go to third line therapy. ففي عنا أدوية في عنا two options هون. Okay. Reserved to the third line or even more. يعني لنفترض مثلا إنه أنا جربت أروح على خليني أفترض نفس السيناريو طلع EGFR wild type ما كان mutated. Okay, بهاي الحالة I can shift in the third line I can shift to the EGFR inhibitor as monotherapy for example لأنه أنا جربت two chemotherapeutic regimens وما كانوا effective. طيب صار progression يعني still the disease not under control. فإحنا عندنا two regimens actually أو two drugs I would say okay that can be considered in at least يعني third or progression after second line اللي هم الريجورافينيب. هذا الدواء هو عبارة عن angiogenesis inhibitor. okay. وفي عنا يعني recently في عنا الترايفلوريدين التيباراسيل هذا كمان chemotherapeutic regimen okay أو أدوية. هدول الاثنين you never start them in the first or the second line therapy. هدول reserved to the disease progression after second line or third line treatment. اوكي. يعني بيجي مريض metastatic disease على الفيرست لاين you consider regorafenib أو نعطي regorafenib مع الكيمو غلط. اوكي. regorafenib is approved for the يعني patients who progress. اوكي. هو angiogenesis inhibitor لكن is not first line angiogenesis inhibitor. فبالتالي after the second or third progression you can think of switching to regorafenib. It can be given as monotherapy or trifluridine tibarasil ممكن كمان هذا ينعطى بعد السكند أو الثيرد progression. أحياناً إحنا شو بنعمل؟ هدول المرضى للأسف if they do not even respond بيضل عنا يا إما supportive care يعني المريض بيتعالج يعني for just the supportive care يعني خلاص the regimen is unfortunately not giving effect. Okay, there is no need to expose the patient to their toxicity فبيضل الموضوع هو supportive. Okay. أو إنه إذا في أحياناً clinical trials going on, okay, we can يعني recommend أو advise joining a clinical trial for some يعني هيك investigational drug use or something. Okay. هلا ال angiogenesis inhibitors approved in colon cancer عنا البيفاسيزوماب حكينا عنه هو EGF inhibitor أو monoclonal antibody. وفي عنا 3 other drugs I think الراميكيورماب أنا مش كاتبته هون مكتوب هون. أوكي طيب رح نحكي عنه هذا. في عنا 3 other drugs approved as angiogenesis inhibitors. They have different dynamics actually. فالزيف aflibercept هو عبارة عن هو peptide بس هو مش full monoclonal antibody وإحنا بنقول له مثل تراب أو fusion protein. أوكي. فالزيف aflibercept لما بينعطى it will catch أو it will يعني بيمسك مع يعني angiogenesis factors أو pro-angiogenic factors. Okay, like VEGF-A. VEGF-A هو نفسه VEGF. Okay. VEGF-B placental growth factor كمان placental growth factor is very important in angiogenesis. فهو التراب فهو لما بيعمل binding أو يعني بيعمل attachment أو بيمسكهم هدول بيعملهم trapping they cannot bind on endothelial cells and so you stop angiogenesis. Okay. لكن هذا الدواء عادة إحنا ما بنفضله بالفيرست لاين إحنا بنعطيه بالسكند لاين. أوكي. طبعا هذا ببتايد فبنعطيه parenteral. الريجورافينيب هو small molecule kinase inhibitor available for oral use. أوكي. هذا له يعني pan activity فإحنا نقول pan inhibitor كلمة pan PAN مثلا والpan molecule small molecule inhibitor معناها له many targets الرينج أو السبيكترم of activity له يعني wide. فهو عبارة عن inhibitor to several important receptors و non-receptors يعني involved بالangiogenic pathways. فمثلا الريجورافينيب can inhibit the kinase domain of the VEGF receptor 1, 2 and 3. اوكي وبالتالي يعملهم inhibition حتى إذا الفيجف ربط مع الريسبتور على endothelial cell the activation is blocked. اوكي. كمان it inhibits other important molecules like RAF and BRAF and RET and others. هي كلها very important downstream transducers. فهو pan inhibitor pan small molecule inhibitor مثل ما حكينا هذا the third or fourth line treatment. اوكي. هلا ال adverse effective profile للangiogenesis inhibitor في كتير overlap يعني بنلاقي انه في كتير similarities between the toxicity of zivabalipercept, regorafenib مثلا والbevacizumab. يعني هاي الادويه كلها بتعمل impairment in wound healing ممكن تعمل tendencies of coagulopathies and bleeding ممكن كمان يعملوا hypertension. regorafenib can actually cause hypertension. اوكي. هلا specifically مثلا regorafenib hepatotoxic فبالتالي المريض لازم اعمل له liver function test in baseline before I start the drug. كمان ممكن يعمل hand foot syndrome. اوكي special to regorafenib. فبالتالي في اشياء in common يعني side effects common للangiogenesis inhibitors وفي side effects to each drug. اوكي. ف they are approved but they are not above or they do not precede مش ما بيجوش قبل البيفاسيزوماب بال guidelines أو when to use. okay. الراميسر الراميكيروماب هو عبارة عن VEGF receptor monoclonal antibody. فهو it inhibits VEGF receptors, but unlike الريجورافينib, this is not a small molecule inhibitor. هذا monoclonal antibody. Okay. فمثل ما حكيت, if we want to consider biologics, we consider one of them, one group. Okay. والمونوكلونال انتيبوديز الانجيجينيسيس انهبيتورز اللي هي البيفاسيزوماب او راميكيروماب والزيب افليبرسبت هو مش مونوكلونال بس هو بيبتايد. هدول عادة should be added to chemotherapy, cannot be used as monotherapy. Okay. بينما EGF inhibitors, as I said, they can be used to patients who are eligible. They can use them as monotherapy. Okay. طيب هلا الميتاستاتيك stage 4 disease colorectal cancer في مرضى they got stabilized بيكملوا الكورس of treatment. نفترض مثلا عندي جات case of unresectable colon cancer and we decided to treat with Folfox and Avastin in first line, and luckily the patient responded, the case was stable. حكينا on average احنا بنعطي الكيموثيرابي to give her 6 months of treatment. Okay. هلا في controversy أو في يعني هيك debate, do we need to consider maintenance therapy in patients with metastatic colon cancer or not? يعني هدول eligible نعطيهم maintenance treatment or not. هلا هذا الكلام off text مش مكتوب بكتابكم يعني بس للمعلومات العامة يعني بما إنه إحنا عم نحكي عن metastatic disease. Some physicians would like to maintain Avastin لهدول المرضى. يعني if Avastin was added to the first-line regimen and patients responded, يعني some physicians recommend to keep Avastin only لحتى إنه يقلل the risk of disease relapse or recurrence. Okay. طبعاً هذا مش FDA approved. ليه؟ لأنه إحنا قلنا إنه Avastin should not be used alone without chemotherapy. Okay. يعني هذا الموضوع لسه ما في clear guidelines about it. Okay. فمعظم المرضى أكيد بيضلوا under surveillance. Okay. لكن the thing about maintenance treatment in the metastatic disease is still, يعني I would say in colon cancer is not that clear. Okay. يمكن بالlung cancer رح نحكي next. لا في clear guidelines about maintenance, what drugs to go for, how to use them. It's clear. لكن بالميتاستاتيك colon cancer is still not very clear. Okay. option to go to maintenance therapy or not هو still debatable. طيب هلا الكانسر treatment in general is going through something we call it personalized medicine. شو يعني؟ يعني أنا I have to identify the needs and I have to identify the genetic makeup and يعني specific specifications I would say of the cancer in this patient and direct my treatment accordingly. pharmacogenomics بالcolon cancer مهمة. I think there is a good part in your text about the pharmacogenomics in colon cancer. أنا هحكي the most important ones. Okay. هلا ال 5FU okay is metabolized through the DPD enzyme. Okay. ال DPD enzyme deactivates أو inactivate ال 5FU. المرضى اللي عندهم deficiency of this enzyme, okay, DPD deficiency, يعني polymorphisms, change in the gene, okay, ال DPD, okay, dehydrogenase enzyme is encoded by the DPYD gene, okay, اللي يصير عندهم mutation or polymorphism in this gene that will lead to deficiency in the enzyme or no activity at all, and the enzyme is inactive completely. هدول المرضى, we should not consider 5FU in the regimen. We should avoid 5FU. Why? Because it might lead to severe toxicity. Actually, في case reports يعني documented بالliterature إنه صار even fatality, death. Okay? This enzyme is very much linked to 5FU toxicity, and this is really important. هلا احنا حكينا انه ال EGFR inhibitors can cause skin rash. Okay. يعني مين الاشخاص او which patients will be more susceptible to the skin rash? يعني we don't know exactly. Maybe it's genetically related. Okay. ال TS thymidylate synthase كمان مهم. Why? Because this is the target of 5FU. Okay. So its expression level is associated with the 5FU activity and toxicity. هلا هذا يعني ممكن يكون البوليمورفيزم له مهم، بس ال DPD كتير مهم مع ال 5FU. Okay. Polymorphism is associated with the ability to accumulate intracellular folate يعني folate reductases. Okay. The genes encoding for folate reductases are very important لأنه if you can actually نفترض مثلا انه في عندي مشكله بالسيل بالكانسر سيل انه cannot accumulate the folate intracellular، هذا رح ياثر على الاكتيفيتي وكمان ممكن ياثر على التوكسيسيتي اوف الفلوروبيراميدينز. ال UTG1A1 enzyme, as I said, هذا كتير مهم we talk about when we want to consider irinotecan. Okay. ف certain polymorphisms يعني this polymorphism here اللي هو بيصير فيه homozygous repeat احنا بنقول له star 28 يعني هذا الاليل اذا كان هذا الهوموزايجوس 7 repeat allele موجود it means that the enzyme is not active at all. Okay. ف if this is the case يعني toxicity of irinotecan will be really severe, could be fatal, especially potential انه يعمل للمريض neutropenia and severe يعني diarrhea. Okay. فيفضل هون يعني إذا أنا عندي polymorphisms associated with a drop in the activity of this enzyme or a polymorphism that will lead that the enzyme is not available, null, مش موجود. Okay. Avoid irinotecan. Okay. Do not use irinotecan containing regimens. Okay. إذا كان عندي DPD deficiency, okay, severe deficiency, avoid 5FU. Okay. Skip it. مثلا go to irinotecan based, for example. Okay. فبالتالي ال polymorphism in the enzymes is important. هلا في جزئية بتخص ال colon cancer. I think it's not written in your book as well, but just to be updated يعني للمعرفة هي مش لأغراض الامتحان. There is a group of drugs حكينا عنها قبل هيك اللي هي ال checkpoint inhibitors وحكينا عن النيفولوماب بالليمفوما. Recently يعني maybe a couple years ago لقيوا إنه مرضى الكولون كانسر ممكن يصير عندهم إشي اسمه microsatellite instability. أوكي. وعلى فكرة هاي MSI مكتوبة عندكم بالكتاب. والmicrosatellite instability ممكن تكون high أو low. أوكي. فلقيوا إنه some metastatic colon cancer patients with microsatellite instability they can be eligible to a very يعني personalized medicine أو ممكن نعطيهم إحنا immune checkpoint inhibitors especially إذا كان عندهم mismatch repair deficiency. أوكي. اللي إحنا حكينا كمان عنهم بالبداية قلنا إنه mismatch repair is يعني deficiency أو impairment بال DNA repair mechanism highly associated with colon cancer. they are candidates to immune checkpoint inhibitors منها البيمبروليزوماب مثلا. اوكي. النيفولوماب. الأدوية هاي approved and can be used وهاي بدها very personalized medicine. يعني لازم أنا أعرف بالضبط هذا المريض الستاتس of the MSI عنده وأقرر على أساسها إنه candidate أو مش candidate. أوكي. فهاي الأدوية approved بس I think it is not mentioned in your book. بس I believe إنه MSI is mentioned in your book. Okay. Microsatellite instability is mentioned. Familiarize yourself with the term. شو يعني MSI؟ Okay. لأنه MSI بنشوفها ب many cancers. الcolon cancer MSI يعني genetic abnormality change is very يعني is very كتير يعني بتميز الcolon cancer إنه rate of MSIs أعلى بكتير من other cancers. Okay. Just keep it in your mind. هلا ال evaluation of therapeutic outcomes المرضى اللي بيجوا stage 1 to 3 عادة if يعني most of them صراحة يعني I've seen يعني colon cancer كتير موجود بالأردن cases are many okay فهدول المرضى يعني many patients in stage 2 or 3 actually who need chemotherapy they do respond to chemotherapy ومعظمهم بيصيروا stabilized يعني أنا ما بتذكر إنه لقينا كتير مرضى إحنا بستيج 3 مثلا وما مر علي أنا شخصيا إنه هم they do not respond أو they progress أو يعني معظم المرضى الريسبونس تبعهم بيكون reasonable وبالتالي بيصيروا off treatment وبيحتاجوا monitoring okay between time and another بيضلوا يعني under observation أو surveillance. disease progression can happen, relapses can happen, okay. فعشان هيك احنا لما بنعطي كيموثيرابي بالادجuvant setting احنا بيكون الالتيميت جول تبعنا to minimize the relapses or recurrences that can happen later on. إذا رجع المريض بعد فترة بديزيز relapse أو recurrence it can happen يعني تعالج مثلا from stage 2 or 3 colon cancer disease free for maybe 4 or 5 years ممكن يرجع المرض later on it can happen okay بنعالج again with chemotherapy we reconsider resectability again إذا كان operable أو لا بنتعامل معه يعني again as a new case okay carcinoembryonic antigen this is really important for follow-up هلا most patients with colon cancer لما بيجوا at presentation CEA is usually elevated but it's not necessarily elevated okay يعني احنا ما بنربط CEA level بالdiagnosis okay يعني مريض ممكن يكون عنده colon cancer CEA levels elevated وكمان ممكن يكون colon cancer with CEA levels within normal يعني we can see these scenarios in most cases it is elevated okay هلا with appropriate treatment surgical and chemotherapy usually the levels decline and we believe that the source of CEA ها بنقولها احنا tumor biomarker okay area of research with the tumor biomarkers is very hot and very big area excuse me فاحنا بنقول له biomarker okay ليش؟ لأنه its levels can tell us something about the tumor okay فبالتالي ال CEA we expect that when patients are responding to therapy when things are going towards a good treatment the levels start to decline from the baseline okay طيب لنفترض إنه المريض recovered مثلا stage 2 colon cancer وإحنا عم نعمل له follow up وبعد 6 شهور أو سنة we start to see إن the readings of the CEA are starting to go up again okay this requires careful and يعني further investigation because maybe this is a sign for disease relapse okay or progression يعني relapse or recurrence يعني إحنا we believe إنه this protein in the blood is coming from the cancer cell فبالتالي its levels reflect something about the cancer cell طبعا في أشياء أخرى يعني في other target tissues أو normal tissues they can produce normally CEA فعشان هيك يعني ارتفاع CEA عند مريض كان عنده colon cancer is sometimes alarming and requires attention okay فإحنا بنعتبره prognostic and predictive أو follow up marker okay مش كل الكانسرز في very specific markers يعني رح نحكي about PSA and prostate إن شاء الله بس مش يعني في مثل ما حكيت في كتير research إنه we try to identify markers to monitor the patient without excessive invasive and يعني radiographic examinations فالbiomarker area the tumor biomarker is a very big very hot area of research actually okay الcolon cancer أهم ماركر فيه هو CEA تمام طيب إحنا we have like 15 minutes left بس I will not start lung cancer today لأنه بصراحة هو a very important big topic يعني خلص إحنا رح نوقف هون ما حدا يطلع لو سمحتوا I will download the attendance list okay طيب we are done for today يعطيكم العافية إن شاء الله next week we will discuss lung cancer okay إذا في حدا عنده سؤال I can take it. اللي بحب يطلع you can leave. إذا في أي طالب عنده سؤال let me know please.
يعطيك العافية.
أهلا، مين؟ ياسمين؟ تفضلي.
بدي
تفضلي
أسأل سؤال. لما نحكي
ياسمين. I
clinical
can't
trial
hear you well.
صوتي هيك
سامعتك.
مسموع؟
Yes. Yes. Go ahead.
لما
تفضلي.
نحكي clinical trial الكلينيكال ترايلز بتكون بمستشفيات ولا بيكون لها أماكن خاصة، خصوصا إذا ممكن يضطروا يفحصوا دم أو يتابعوا الأشياء بشكل شوي انتنسيف أكثر من المعتاد. يعني شو الشروط اللي يعني إحنا عارفين إنه في أشياء كانت بالنهاية الخيار إنه ينعمل لها كلينيكال ترايل، بس الكلينيكال ترايل بيصير بأي مستشفى متخصص بالكانسر ولا له شروط معينة؟